I'd like to thank the chairs and the committee for the privilege to present this study. Lung cancer invading the chest wall is defined as tumors invading the parietal pleura or penetrating ribs or skeletal muscle, sometimes in vertebral bodies. The prevalence of chest wall invading lung cancers is around 5%. Long-term survivors are associated with complete resection and node-negative disease. This study aimed to identify the long-term survivors and identify some prognostic factors for long-term survivors within the patient performed with combined chest wall resection for primary lung cancer surgery. This is a retrospective study based on the database from the Seoul National University Hospital from 2004 to 2017. We identified combined chest wall resection, including parietal pleura alone, lips, and vertebral bodies for chest wall involvement of lung cancer, which was confirmed in pathologic T3 or T4 tumors, regardless of lymph node status. We excluded surgeries for recurrence or metastatic regions and stage 4 disease. The 7th TNM staging system was applied. This table showed the details of 154 patients. The median age was 60-year-old with male predominance. 2/3 of the patients underwent surgical resection under open technique. Lobectomy was the most frequently performed. Skeletal resection was performed in 54% of the patients, and extrapolar dissection was performed in 71 patients. Neoadjuvant chemotherapy was employed in 11%. Clinical T3 and T4 tumors are dominant, and clinical N2 disease was identified in 16%. Adenocarcinoma and squamous cell carcinoma accounted for 45% each. This table showed the pathologic results. Stage 2B is more frequently found than stage 3A. The median tumor size was 5 centimeters. R0 resection was achieved in 94%. T3 tumors are accounted for 93%. Pathologic N2 disease was almost 20%. When we see immediate postoperative outcomes, postoperative complication developed in 40%. There was no mortality within 30 days. However, 90-day mortality was 4.5%. The complications are mainly related to respiratory issues. Adjuvant chemotherapy delivered in 52% of the patients. Radiotherapy in 80%. Recurrence developed in 81 patients. Distant metastasis was the main cause of death. These are survival results. From the entire population, 5-year overall survival was 40%, and 3-year recurrence-free survival was 37%. R0 resection was associated with better survivals, and incomplete resection was leading to death within 2 years. Clinical N2 disease showed significantly worse survival than N0 or N1 disease. For the recurrence, N2 disease showed worse recurrence-free survival without statistical significance. For the extent of chest wall resection, patients who underwent extrapolar dissection showed similar overall and disease-free survivals with those who underwent skeletal resection. There was no significant differences in survivals according to the adjuvant chemotherapy. When we figure out the time to develop the first recurrence according to the pattern of recurrence, distant metastasis developed significantly earlier than those with local regional recurrence. We identify some prognostic factors for survivals. Tumor size, and clinical end-to disease, and T factors were associated with poor survival. In addition, adjuvant chemotherapy was a significant factor for better survival. When we see the prognosis factors for recurrence, tumor size associated and incomplete resection and female sex were significant factors for recurrence. We described the long-term survival and identified some prognosis factors for survival. The tumor size influenced both of overall and recurrence-free survivors in this study. And the adjuvant chemotherapy is necessary for stage 2B and stage 3 lung cancer. However, the delivery rate of adjuvant chemotherapy was quite low, which might be induced by the decrease in performance status after extensive surgeries. Thank you for your attention.